Good morning. I am Eileen Chua, a third-year cardiology fellow, and I'm here to give an orientation on the acute myocardial infarction clinical care program. The AMI program is a service offered by the TMC CVI to patients admitted for acute MI or heart attack. The program involves the different subspecialties of the Cardiovascular Institute and ancillary services to provide patients with the highest quality of care based on recent clinical practice guidelines from both local and international scientific societies. Our mission is to be the leading heart attack center by offering quick, cost-effective cardiac care through a comprehensive network within Pasig City, and to be able to reproduce this to TMC South Luzon, Clark, and Iloilo. The vision is to establish TMC as a regional STEMI center for Pasig City and to be a model for reperfusion in the Asia-Pacific region. We have started working towards this goal with the Hub and Spoke program, which involves working with Pasig hospitals without a cath lab to allow patients there to receive necessary heart attack interventions that are available in our institution, ultimately with the goal of improving clinical outcomes. We are the first and only AMI program accredited in the country and number 8 in the world. Our first accreditation was in 2015 and we were re-accredited for the third time just last year. The program has 5 components and 9 core measures. The 5 components are revascularization, either fibrinolysis or angioplasty, cardiac rehabilitation, pharmacy, nutrition management, and smoking cessation. Given the 5 components, our 9 core measures are as follows. To make it easy for everyone, just remember that we give aspirin as soon as possible and make sure it is continued at discharge. ACE or ARBs, especially if the patient has heart failure. Beta blockers for heart rate control and statins, or medications for cholesterol and plaque stabilization. Of course, all meds should be given only if there are no contraindications, such as allergies or other comorbidities. For STEMI, immediate reperfusion is critical, either fibrinolysis or angioplasty. For a more holistic care, we also ensure that smoking cessation counseling is given for active smokers, that morbidity and mortality is monitored and followed up, and that cardiac rehabilitation is advocated to allow patients to return to their previous level of activity as soon as possible. So, where do all these come in? Let's start with which patients can be included in the AMI program. The only criteria is that the patient is 19 years old and above and is suffering from chest pain or any chest pain equivalent, such as epigastric pain, shoulder pain relating to the jaw, among others. They can be patients at the ER or patients already admitted. When a chest pain is confirmed, the chest pain pathway is activated. We have pathway forms for this to help with ruling out non-cardiac causes and ordering diagnostics and initial management. We're still working to incorporate this to ARCOS, so for now, we still use the forms as a guide but order through ARCOS. Once chest pain is attributed to a heart attack, patient becomes eligible to be enrolled to the AMI program. So when the patient has chest pain or angina likely due to a heart attack, an ECG should immediately be requested to differentiate the two kinds of MI, ST elevation MI or non-ST elevation MI. Both are enrolled in our program as long as the MI is type 1 or due to an atherosclerotic plaque rupture and thrombosis. Going through the more urgent type first. If ECG shows ST segment elevation similar to the ECG showed here, we activate code STEMI. This is done by dialing 88 and can be activated by anyone in the healthcare team. Paging system will call code STEMI and cardiology fellows immediately respond to assess if the patient really has ST elevation MI. For STEMI, the most important intervention is to reopen the occluded coronary artery, either through angioplasty, so we bring the patient to the cath lab to reopen the occluded artery through balloon and stent placement, or through fibrinolysis, where lytic agents such as reteplase are administered through IV to dissolve the clot. But why the urgency? Because we have to meet target times. Before, we used door-to-needle and door-to-balloon of 30 minutes and 90 minutes respectively. We still measure this, but now we prefer to use STEMI diagnosis to lysis of 10 minutes or STEMI diagnosis to crosswire during angioplasty of 60 minutes. We adhere to these strict targets because time is cardiac muscle. Every minute that the artery remains occluded means more cardiac muscle dies, which may eventually cause heart failure, arrhythmias, and other complications, which we try to minimize as much as possible. Aside from revascularization, another critical part of management is immediate administration of ACS medications, which we usually give at the ER even before bringing to the cath lab. We usually give loading doses of aspirin, ticagrelor, or clopidogrel, along with standard doses for enoxaparin, pantoprazole, and atorvastatin, and are continued during admission. This regimen may still vary depending on physician assessment. After revascularization, patient is admitted to the ICU or if hemodynamically stable to 7B telemetry. It is at this time that the patient is enrolled to the AMI program. The CFOD will secure consent and fill up this stamp. This is how it looks like in ARCOS to make sure all components of the program are provided. If you'll notice, these are mostly the 9 components we mentioned earlier. Once enrolled, other interventions are administered. Along with the medications, cardiac rehab, smoking cessation, nutrition, and pharmacy counseling are done. After 3 sessions of cardiac rehab, or once the patient is more stable, he is discharged and advised follow-up. For patients without ST elevation or NSTEMI, although revascularization is an important intervention, we have more time since the artery is not totally occluded. Patient is managed medically with the ACS regimen previously mentioned, but angiographic intervention is planned usually within 24 hours. Patient is admitted to 7B telemetry and undergoes the other interventions of the AMI program as mentioned earlier. Please note that for patients with NSTEMI but show signs of hemodynamic instability, such as hypotension, arrhythmias, or even cardiac arrest, the intervention follows that of STEMI. Both types of patients will undergo secondary prevention and counseling once more stable in preparation for discharge. One important part of the AMI program, which is usually used in the ER, are the AMI packages. These contain diagnostics and ancillary management important for AMI patients, but these can be ordered even if the patient has not consented to the program yet. Ordering as a package gives patients discount from regular rates and can already be ordered in ARCOS. This is an example of an AMI package ordered in ARCOS. By ordering AMI package A, you get all the listed tests already. For meds, we don't have a package for that, but we use an order set to make ordering easier. We also have 5 AMI pathways for the different interventions we mentioned earlier. We're still in the process of incorporating this to ARCOS. But the most important thing to remember are the 5 components and 9 core measures we mentioned earlier, as this is the backbone of our AMI program. Having all these elements on board ensures better outcomes for our patients in the short and long term. Last but not the least, another important part of the program is follow-up. Care does not end with discharge as these patients are followed up at 1 week, 30 days, 90 days, and 1 year by our Continuity of Care Contact Center. That ends the overview of our AMI program. If you have any questions, you may direct them to our program director, Dr. Paulo Prado, our AMI nurse, Ms. Joanne Kiambao, or any of the cardio consultants and fellows, and we'll try our best to address them. Thank you for your kind attention and have a good day.